Thank you, Juliana. It's a great pleasure to be talking with you today. I'll try to provide a smooth transition between lunch and the program of this afternoon. The title of my presentation seems to imply that we've solved the problem. You're going to realize it's pretty much a work in progress. So this slightly outdated picture, I think you can spot Adrian in the picture, represent the reason why I became interested into dystonia. And I became interested because I witnessed how big the presence of dystonia made an impact on the clinical decisions that the physiotherapists and the surgeons were making at the gait lab at the Children's Hospital. So every Friday morning during reporting, we try to analyze all the gait analyses that had been captured in the past week or the past few weeks to try to determine the gait impairments or the musculoskeletal problems that affect the child walking, and trying to establish a surgical plan to address those problems. Sometimes the word dystonia appears in the discussion, and when everyone was agreeing about a plan before, now this plan has been discarded and we have to start all over again. So dystonia has a huge impact on the decision we take in the gait lab. And most of the time we've got very rudimentary tools to assess dystonia. We are playing a video of the child walking in the background, and someone realized that there is a specific hand posture or upper limb posture, and then throw the big word dystonia, and everybody freeze, and we start all over again. So I felt this was probably a little bit too subjective, at least to my liking as an engineer, and therefore I embarked on ways to try to measure the presence of dystonia objectively. So this is my pathway towards this goal. So I initially associated dystonia with movement variability. I understand now a little bit better about dystonia, and I know that it's not all about movement variability, but that was my initial hypothesis, and so that's where I started. Since we collect gait data, I started to build a gait kinematics variability index. So to think about this index, so these are the curve that we collect during gait for the knee flexion on the right and the left-hand side. We collect approximately 6 strides, so you've got 6 blue curves and 6 red curves. And to visualize what the kinematics variability index does, you can think about the index as being proportional to the shaded blue area. And so we can calculate an index that gives us a metric about how variable the gait pattern is for one joint, here the knee flexion, but we can also calculate a summary index that takes into account all the joints in the lower limb. So on this picture, this is the typical graph array that we look at in gait analysis. The first row is the movement at the pelvis in the 3 planes, the second row is the movement at the hip, the third one is the knee, and the last and bottom one is the ankle and the foot. So we can come up with a calculation that gives us an overall number that summarizes how variable the gait pattern is. And in this case, it's 3 degrees in average for this child who was 11 years old, GMFCA3, with spastic diplegia. That gives us a way to compare the gait pattern of this child with this other child that is also 11 years old, also GMFCA3, but has dystonia. And in this case, our summary index gives us a variability of 7.7 degrees. So this is a new tool that we validated that has been published recently, last year in Gait and Posture. This publication is quite technical. It's all about the technicalities of the index and the validation. And we've also looked at how the index was sort of changing with age. And so we applied the index on gait data that were collected on 35 typically developing children and we looked at how the index changed with age. So the first few things that we found was that the index was quite accurate, and more accurate, in fact, than spatio-temporal parameters. It only required 6 to 10 strides to be precise. And also, it was showing a very large correlation with age. So it was sensitive enough to be able to detect the change in maturation of gait in typically developing children. So we were hopeful that would help us into differentiating patients with different type of movement disorders. So we've got this new tool, and the question we had was, does it discriminate patient with dystonia from patient with spasticity? So we queried our database, and we looked at all the first appointments from patients that we've seen since 2004. We had a range of cerebral palsy subtype. The blue ones are spastic, so spastic hemiplegia, spastic diplegia, spastic tetraplegia. I know I should not only put diplegia without the word spastic in front of it, but that's what I've done. At least I changed the color. It's blue for spastic, and it's red for dystonia. So that returns, this search through our database returns 426 patients. You can see that a lot were in blue. So spastic diplegia, we had only 8 dystonia. That's the primary disorder, though. We found out that there was no difference between the affected limb and the unaffected limb in patients with spastic hemiplegia. So we combined the 2 limbs for all patients, and that gave us 852 limbs to analyze. So we fit a statistical mixed effect linear model with CP subtype as one of the fixed effects, GMFCS level 1, 2, and 3, and 4 age category under 5, 5 to 10, 10 to 16, and older than 16 years old. The result of the statistical models are these. We also find a decrease in gait variability with age categories. We found a moderate effect of GMFCS level with increased variability of gait with increased GMFCS level. But the biggest, the most striking effect was CP subtype. As you can see, the 3 spastic subtypes were pretty much the same in terms of gait variability, but the dystonia subtype was markedly different and markedly increased. So we thought we were on the right path. I'm going to present those results, the same results, but slightly different way. The x-axis is the age, and the y-axis is the overall gait variability measure. The black dots are the children, the typically developing children. You can see the decrease in gait variability with age. If I plot on top of this the children with spastic hemiplegia, you can see that variability is increased, but not that much. I can plot the children with diplegia and tetraplegia as well. You can see that they all fit nicely together. Now, if I plot the children with dystonia, you can see that there is in general an increase in terms of gait variability for similar age. But at the same time, you can see that there is some overlapping. Some blue points are in the area of the red points. So our index could not discriminate completely patients with dystonia as their primary disorder from patients with spastic hemiplegia, diplegia, and tetraplegia as their primary disorder. There are several limitations with this index as it is. First, what I just mentioned, there is an incomplete discrimination between groups. The main issue we have is that in our database, we only record the primary disorder, so it's either spastic or dystonic. It's likely that a lot of the patients that were in this sort of red circle present a mixed disorder with a little bit of spasticity and a little bit of dystonia at the same time. The second limitation is that we had only a small number of children with a primary diagnosis of dystonia, and that's, as I now understand, mainly because our requirement as gait analysts is that the children are ambulant, and a lot of children with dystonia aren't ambulant. So I looked at back at the literature. Maybe I should have done this before, but that's the way it goes. I found alternative protocol to measure, to try to measure objectively the presence of dystonia. The first one is performed during physical examination. It's a very recent study published by Kami and colleagues, and it's titled An Electromyographic Protocol that Distinguishes Spasticity from Dystonia. They use overflow as their the quantity that they try to measure, and basically they analyze the electromyographic activity of one leg when you do something to the other leg, or when you ask the child to do something with the other leg. So that's quite interesting because you can perform this during physical examination and you don't need the child to be ambulant. The second protocol that I liked a lot use upper limb movement. It's published by Gordon et al. In 2006, and it was titled Can Spasticity and Dystonia be Independently Measured in Cerebral Palsy? So these are the schematic for the protocols. The dystonia is measured from the pictures B and C. And the idea of picture B is that while the child is touching his nose with, for example, the right limb, upper limb, then the electromyographic activity on the contralateral limb is measured. And so that measures the overflow when the patient is doing a voluntary movement. Picture C, in this case, the child has to touch a ball, and what is measured in this case is very similar to what we measure with gait, is the variability of the trajectory and how steady the patient can hold the finger on the ball. So it's very similar to what we've been doing, but it's a little bit more applicable as a clinical assessment tool since it works with the upper limb instead of gait. One of the main issue I've seen is that those two protocols have been published. One has been published in 2006, and I haven't been able to find other groups replicating the findings. So I thought, how come? Like, it looks very nice, and it was 11 years ago. So I thought, in principle, people would have reproduced the findings. I think what happened is it requires a gait lab. It requires equipments that are available in a setting that is already quite busy with doing gait analysis and might not be accessible to do routine clinical assessment for a patient with dystonia. And so I thought we can devise alternative protocols, but in this case, that instead of being in the gait lab, use wearable sensors. So wearable sensors, in terms of capturing electromyographic activity, which we've seen is quite important. They've existed quite for a long time, in fact. The system on the bottom end is from Delsis. The system on the right end is from Cometa. It's quite a mature technology, and as you can see, you can even capture muscle activity during swimming wirelessly. There is no cable attached to the little electrode. In terms of capturing movement, that's a little bit more recent, but new advance in miniaturization of the sensors have allowed this kind of box to appear. This box is about 4 centimeters long. It's that big, really. And inside the box, you've got 3D accelerometers, 3D gyroscopes, and 3D magnetometers. Those three types of sensors working together allows to have a good idea about the orientation of the box in space. So you could do kinematics. It has started as devices to have very good-looking gaming tools. But it's more and more used in sport biomechanics because it's very convenient. You can bring your system in the field and start capturing the movement of the limbs. So I think those two types of sensors, wearable sensors, should allow us to reproduce those protocols outside of a gait lab. And Melissa Louis, who's here today, is going to start the first part of her PhD just about this. She'll try to devise a protocol to quantify the presence of dystonia using innovative solution with wearable sensors. And our first aim is to reproduce and complement the previous findings of this study. And ultimately, our goal is to be able to provide a flexible and portable clinical assessment tool. And I'm finished. Thank you.